Alright, so in this unit we are going to be talking about the cardiac cycle, what happens as atrial and ventricular systole and atrial and ventricular diastole are occurring, and then a little bit about how we control the cardiac cycle and how the cardiac conducting system, those cells, those cardiac muscle cells that are responsible for transmitting the signal to contract, how they do their thing. So let's get started. So when we use that term systole, and you actually say that E, it's not systole, it's systole. When we use the term systole, we're talking about the contraction of the chambers, atria or ventricles, doesn't matter which. So there's atrial systole and ventricular systole. And it's during contraction that blood is pushed from the chambers. And the term diastole refers to relaxation of the atria or the ventricles, depending. And it's the time when the pressure of the of either the venous system or of the the pressure that's produced as the atria contract forces blood into the chambers, and the chambers stretch and fill with blood. And associated with those terms are blood pressures. And so when you hear that term systolic pressure, that's the pressure that's generated in the arterial system in response to ventricular systole, specifically the contraction of the left ventricle when we think about blood pressure. And the term diastolic refers to the pressure generated in the arterial system as the chambers, specifically the left ventricle, relax. So this is the lowest blood pressure that the arteries see, while systolic is the highest blood pressure that the chambers will see. All right, so the valves of the heart, they open and close not because of any kind of muscular contraction, but instead based on the differences in blood pressure on either side of the valve. So when the ventricles are relaxed or in ventricular diastole, and the blood pressure in the ventricles decreases, then it's the pressure of blood in the atria that forces blood through the atrioventricular valves, that opens up those valves and forces the blood through. And if you recall, the way the valves were constructed, so here is the wall between the atria, and down here are the ventricles. And if you recall, the valves are just flaps of connective tissue that are connected back to the wall of the ventricles by those chordae tendineae. So when the ventricles have low blood pressure, then there's sufficient pressure in the atria to force blood through those flaps, and so the ventricles will fill. And then the atria can contract more. So as the atria do their squeeze, then that raises blood pressure even more, and so even more blood is forced out of the atria and into the ventricles. Now, as the ventricles contract, they've got much more muscle to them. Then that dramatically increases the pressure inside the ventricles. So now the ventricles are under high pressure. So some of the blood and the pressure of the blood force the two flaps closer together so that no blood can leak back out. And that's, again, the job of these chordae tendineae, is to prevent prolapse of the valve. Because if there was no little straps holding the valve shut, then it's possible that one of the valves could flop backward. So the prolapse would look like this, or some version of this. I'm going to be really dramatic and have the whole flap flopping back inward. But rather than sealing up now, this would be pushing toward trying to seal, but it would have no mate, and so the blood would sneak back out through the valve. So as the ventricles contract, pressure in the ventricles really increases, the atrioventricular valve snaps shut. Poop. Okay, so it doesn't make that noise, but you get what I'm saying. The papillary muscles will contract. Remember, we've got the papillary muscles here where the chordae tendinii are connecting back to the wall of the ventricles, and that prevents prolapse. So at this time now, the atria have completely relaxed, and blood is moving into them in preparation for the next cardiac cycle. But as the ventricles are contracting, they're pushing blood up and out through the base of the heart, either through the pulmonary trunk or through the aorta. Sorry, I'm drinking coffee. That was a little bit noisier than I meant for it to be. So the ventricles are going to continue to contract. Pressure in the ventricles really increases and continues to keep the atrioventricular valves closed. And now we're going to move the blood out of the ventricles, either through the pulmonary trunk or the aorta. And so this time, so now if we can draw the semilunar valves, so here's, let's say we'll think about the aorta. Here we have the cusps of the semilunar valve, and here is the ventricle wall. So as pressure in the ventricles increases, and remember it's closing off the AV valves, keeping them closed, now note the orientation of the cusps of the aortic valve, and it's the same for the pulmonary valve, or the aortic semilunar, pulmonary semilunar valves. As pressure increases, now it's the pressure here in the aorta that the ventricles have to overcome. And if you think about a person who's healthy, maybe their pressure is about 70 millimeters mercury in the aorta. That would be, that would be the lowest blood pressure that we're imagining here in the aorta. So the pressure increases above 70 millimeters mercury, and that then opens the aortic valve. And so now blood can flow out into the aorta. So push, push, push. The ventricles reach maximum pressure all the way up to, say, 120 millimeters mercury. And then they start to relax again. Now, when the blood pushes into the aorta and into the pulmonary trunk, it'll kind of expand a bit. So I'm using these dotted lines to show the expansion of the aorta. It just stretches. It's very the wall of the aorta and the pulmonary trunks. Most of the arteries have a lot of elastic fibers in them, and so they can stretch some as they absorb all of that pressure that's coming into the aorta. Then as the ventricles begin to relax and the pressure inside the ventricles starts to ease again, the aortic walls will snap back into their previous shape, and that provides sufficient pressure to close the aortic valve and the pulmonary valve, close them back up, snap them shut. Now at the same time, the atria over here are going to be starting their contraction cycle, and that's going to force open the atrioventricular valves again. So in the cardiac cycle, first the atria undergoes systolic or systole. Then as they're undergoing diastole, the ventricles are undergoing systole. And then as the ventricles begin to relax again, the atria undergoes systole again. So it's this sharing back and forth, squeezing downward, whoosh, and then if you can imagine squeezing back upward again, pushing blood up and out through the aortic and the pulmonary valves. So it's all about pressure, and as the pressure in one chamber of the heart increases, it pushes blood into the next chamber of the heart. As the pressure in the ventricles increases, it pushes blood out through the pulmonary trunk and the aorta. And we can listen to those sounds. So the sounds that we hear as we do auscultation of the heart, I love that term. That means listening, and it's usually done with a stethoscope. It allows the discrimination of two different heart sounds as you listen. There's lub, and this is the sound of the AV valve snapping shut as the atria are relaxing and the ventricles are beginning systole. And then there's dup as the aortic valves are closing toward the end of ventricular systole, or at the end of ventricular systole, and as the valves ventricles are relaxing into diastole. So lub is the AV valves closing, dup is the pulmonary and aortic valves closing. Okay, so how do we regulate all this? How is it that the heart communicates amongst all of the cardiac muscle cells? How do they communicate that it's time to contract? So we got to step back for a second and think about the heart as a whole. So if this, there we go. Okay, there's the heart. Here are the great arteries and veins leaving the heart. Up here toward the top, we have the atria. Down here toward the bottom, we have the ventricles. Okay, so there we are. It turns out, again, because cardiac muscle cells branch, so if you remember my cheesy drawings, cardiac muscle cells, they always look like this with these branches. And the branches were connecting multiple cardiac muscle cells together so that they have these areas of gap junctions. So here's, okay, so I'm going to stop with my terrible drawings now. But this heart muscle cell it connects to this one, which also connects back to this one, and then there's one that's connecting back to both of these, and so on. So they connect to each other by gap junctions, which allows a lot of communication of ions between the cells. So whatever insulation they might have is overcome by the fact that they're communicating. And so the signal to contract spreads quickly through all of these interconnected cardiac muscle cells. And the myocardial cells of the atria are all connected, but there is a bunch of connective tissue that separates the atria from the ventricles. So the atria are all interconnected, the cells of them in the myocardium. All those cells are interconnected to each other, and they form what is referred to as the atrial syncytium. It's a weird term. We say it syncytium. Syn means with or together. Cyte means cell. So these are all the cells that are connected together. And if they're the atrial cells, then it's the atrial syncytium. And the ventricles are also all together connected, forming what's referred to as the ventricular syncytium. But so if one of these cells up here in the atria gets the signal to contract, then that signal to contract is going to spread like a wave across the atria. And the same thing in the ventricles. If one of these cells down here gets the signal to contract, then the signal is going to spread like a wave across the ventricles. But there's this blockage here, this firewall, you can think of it as, in between the atria and the ventricles that ensures that just because the atria contract, we don't see corresponding spread of contraction throughout the ventricles. So the atria and the ventricles can contract without causing the other chambers to contract. Hope that makes sense. Okay, so before we can talk again about how all this works, we've got to do a little bit more defining of the cardiac conduction system cells and the type of cells that we find there. So the cardiac conducting system is composed of muscle cells, cardiac muscle cells, that do not contract. Instead, they pass the signal to contract onward through the heart tissues. So they're almost like the nerves of the heart. So we don't have neurons that are spreading throughout the heart. We have neurons that connect back to certain cells, but it's not neurons that spread throughout the heart, spreading the signal to contract. It's these cardiac conducting system cells. And within the cardiac conducting system cells, we have two types of cells: node cells, which are capable of generating spontaneously on their own, without any nervous input, a depolarization, and then spreading, and then when that depolarization develops, then it can spread among any interconnected cardiac muscle cells, and we see contractions in response to that depolarization. So there are node cells that can spontaneously, on their own, stimulate first a depolarization, and then causing any attached muscle cells, contracting cells, to start a contraction. And then there are also conducting cells. So these are cells that, once again, they do not contract, but they do spread. They can carry that impulse to contract. They produce, they connect to node cells, and they conduct a action potential across their membranes, essentially. To look ahead here to see where we're going. Okay, so we see two node clusters of node cells. There's the sinoatrial node, sino because it's located near in the atrial because it's located in the wall of the atrium. Sino because it's near the sinus, the coronary sinus, where venous blood from the heart returns. The coronary circulation of the heart returns back to the right atrium. So the sinoatrial node is found in the wall of the right atrium, and it's a cluster of node cells that can produce very rhythmically 70 to 80 action potentials per minute that will spread across then the atrial syncytium, and they cause atrial systole as they spread. So they're busy going boom, 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 setting the pace of the heart. And because they produce 70 to 80 of these action potentials every minute, we see 70 to 80 contractions of the atria every minute. There's a second cluster of node cells also in the wall of the right atrium. It's in that separating wall between the right atrium and the right ventricle. It produces a little bit faster rhythm of action potentials. They're also very rhythmic, but they're going boom, 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 boom. And because they are connected within the atrial syncytium, they receive the faster boom, 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 versus boom, boom, boom. They receive those faster action potentials that are being spread from the SA node, and they generally don't have a chance to create their own rhythm. So each time they're about to contract using their own rhythm, boom, the SA node's rhythm beats them to the punch. And so they contract in sequence with the in time with the SA node's contraction rate rather than their own. Now, if something were to happen to the heart and the SA node stops functioning, then the AV node, here's the good news, the AV node will take over and will produce its own rhythm. But what we see is that people who have a malfunctioning SA node have a much slower heart rate when the AV node takes over, because rather than getting 70 to 80 of these action potentials every minute, they're getting, about 50, somewhere between 40 and 60 action potentials per minute. So usually the AV node is preempted, doesn't have a chance to to do its own rhythm, as long as the heart is healthy. But it does have a second function. It is able to send the signal to contract across that firewall between the atria and the ventricles. So when it receives the SA node's signal to contract, then it will hold on to it for the merest of time, for less than a second. It just hangs on to that signal to contract very briefly, delays it, and then it transmits the signal across the firewall, across the connective tissue that insulates the atria from the ventricles, and delivers it now down to the conducting cells that pass through the ventricles. Okay, so we've got two nodes, and then we have the conducting cells. And if you're looking in your book, I want to encourage you to look at the image of the cardiac conducting system, the one that I'm asking you to learn for the exam. If you look through those, look at those pictures, you'll see the AV bundle. So that's a cluster of conducting cells that have a layer of connective tissue insulating them around it. They conduct the impulse to contract. They conduct that action potential down to the right and left bundle branches. And without the, or because it's well insulated, then it doesn't leak out any signal to contract. So notice where we're delivering the signal to contract to. Down through the interventricular septum to the right and left bundle branches. Again, they're insulated, and the right and left bundle branches split the signal now, and they transmit it all the way down to the apex of the heart. And then the bundle branches turn and run up the lateral walls of the heart until we get to the Purkinje fibers. Remember, these fibers, they transmit the signal to contract up into the endocardium that lines each of the ventricle walls. And that's where we now release the signal to contract out to all of the ventricle cardiac muscle cells. And we see a contraction that begins from the apex of the heart and then spreads upward, pushing the blood up and then out through the great arteries and veins of the heart. Okay, so now we've got the whole picture. Atrial contractions begin at the top of the atria and spread downward. So that contraction starts at the base of the heart and squeeze, pushes blood from the base through the atrioventricular valves. And then ventricular contractions are initiated down at the apex of the heart, and they spread upward, forcing blood from the ventricles up and out through the pulmonary trunk, and then the pulmonary right and left pulmonary arteries, and out the atrium. So up at the base of the heart. And recall, if you look at figure 1520, I've already had you look at this once, but if you look at it again now, and recognize that the grain of the cardiac muscle cells wraps around the ventricles. This contraction that starts at the apex of the heart and spreads upward causes the heart to twist as it contracts, twist just ever so much, and kind of wring the blood out of the heart, really getting a very effective squeeze that not just comes in laterally, but also draws the apex toward the base of the heart, really wringing out the blood from the heart. Okay, so the last piece of this has a lot of information in your notes package, so I did not include them in this presentation, so I'll let you read through it. But what I want you to know is that there won't be a huge amount of information where I'm asking you to interpret electrocardiograms. So while this is important, I don't want you to over-focus on this part, because you're not going to see a lot of questions about electrocardiograms. But they're called ECGs, electrocardiograms, or sometimes EKGs. because the machine, the electrocardiogram, was first developed in Germany, and their spelling of the term cardio is with a K, and so that's why EKG is also used. So it's just a way to visualize the electrical signals that are occurring in the heart. So all of what's going on electrically with the heart as these depolarizations occur. And so as depolarizations occur, we see waves being printed out. And then they can be interpreted. And so there you are. Everything that you ever wanted to know about how the cardiac cycle works and how we regulate that or control that through the action of the node cells and the cardiac conducting cells. Okay, so there we go. We are done with this one. And